passionate about. I'm sorry, I'm just trying to see. Can you guys see my screen, full screen, or do you see the side notes?
No, we see the full screen.
Okay, perfect. So thank you again for inviting me. This is something that I'm very passionate about. I think cellular therapies are being more and more used as part of treating all oncology cancers, not just heme malignancies, which is what I specialize in. So I'm really trying. I wasn't really sure what is known about cellular therapies at Northwell, and truly what everyone's baseline knowledge is. So my goal today was really to give a more of a bird's eye view on CAR T cell therapies, allotransplant treatments in order to, and their complications that our patients go through, in order to have everyone know a little bit more about what patients face and how patients are thrive after transplant. A lot thanks to your help in making them feel much better, gaining their strength back afterwards. Is the slides moving?
Yes.
Yeah.
Okay, perfect. So here's an outline of what I'll be covering in today's talk. We'll start with the changing landscape in the cancer treatment, how cellular therapy has emerged as a major shift from traditional chemotherapy. We'll focus on two main types, as I mentioned before, CAR T cells and allogeneic transplant. We'll look at how they work, what they're used for, and complications that arise that you may see on your side post-transplant. So to begin our discussion, I wanted to take a step back and kind of look at the treatment on how the treatment of cancer has fundamentally changed over the past few years. For a long time, chemotherapy was our only option, powerful, and chemotherapies are drugs that kill rapidly dividing cells, including the good and the bad cells. Over the years came targeted therapies, which really target specific pathways or proteins. Treatments that you may have come across or heard about, dasatinib, imatinib, midostaurin. These are all small molecules that target specific proteins on cancer cells. Parallel to that came immunotherapy, which really are drugs that are utilized to modulate someone's immune system in order to better react to cancer cells and to lead to the killing of the cancer cells. And then from the immunotherapy, cellular therapy was actually there previous to it. We have just now modulated how we use our cellular therapy and the creation of the CAR T cells, which is really a novel therapy that we'll talk about. So what used to be a field driven by the treatment with chemotherapy is now a shift in utilizing more treatment paradigms that are designed to enhance the body's immune activity against cancer. So what is cellular therapy? Okay. So cellular therapy refers to treatments that use living cells, primarily immune cells or stem cells, to treat diseases. Unlike traditional drugs, these therapies use the body's own or donor cells as the medicine. Cellular therapy is used in a variety of subspecialties, not just oncology. However, in oncology, we use cellular therapy to do one of three things. Either we're using cellular therapy to boost the body's natural immune system, such as in CAR T. We use cellular therapy to reboot or rescue the blood in the immune system, such as in auto transplants. And thirdly, we use cellular therapies to replace the body's entire blood and immune system with a healthy donors, such as in allotransplant. So I apologize in advance for the coming slides. You'll see that there's a lot of emojis appearing on your screen. I use this once for patients to explain to them why we modulate the immune system. And since then, I've been told that it is a great way to explain what cellular therapies are. So the immune system is designed to recognize abnormal cells and to destroy them. When a T cell recognizes an abnormal looking cell, the T cell activates and releases cytokines downstream in order to recruit more of the T cells and destroy the abnormal cell. However, cancer is smart. It can mutate, grow little horns like this little emoji in the middle, to mutate to escape the detection. It may stop presenting the proteins that the immune system uses to recognize it, or it starts expressing proteins that make a local environment, suppressing the activation of the T cells. So this is what cellular therapy attempts to correct in order to minimize the evasion of the cancer cell from the immune system. So as of now, the vast majority of FDA-approved cellular therapies are for hematological malignancies or benign diseases such as sickle cell. Currently, we use auto transplants for multiple myeloma or chemosensitive lymphomas. We use CAR T cells. We use allotransplant as a curative treatment for myeloproliferative diseases, leukemias, and sometimes for lymphomas. CAR T cell therapy is truly approved for B cell neoplasms or multiple myeloma and lymphomas. Some indications are there for B cell acute leukemia, but because it is using a T cell of the immune system, we do not have CAR T products as of yet for non-B cell malignancies. They are coming, they are all in clinical trials, and you will see more and more of them as the years, as the clinical trials complete. So let's start by talking about CAR T cell therapy, which is really the newest cellular therapy that we use that is FDA approved. The goal of CAR T is to improve the function of the immune system. So CAR T cell, CAR T stands for chimeric antigen receptor T cell. And the philosophy behind it is that cancer cells express these proteins on the cell surface, these purple arrows on that red circle. Immune cells are the blue circles. They do not express a receptor to detect those purple arrows and to initiate the cytotoxic cascade. So with T cell, what we are doing is CAR T cell therapy refers to the process of modifying someone's own T cells in a lab so that they can now express the appropriate receptors, those green little flags, in order to bind and attach to the cancer cells in order to activate the cytotoxic cascade. This type of therapy has amazing results with nearly 80 to 90% response rates in patients who have had no response to traditional chemotherapy agents. So this is really why the response rates and how well patients respond to CAR T cell therapy, or that their disease goes into remission, why there is so much interest in bringing CAR T cell therapy into different diseases such as solid tumors, rheumatology, neurology, etc. So for a patient, and it's important to know what a patient goes through in order to get these CAR T cells therapy. So once a patient is evaluated and decided that they will pursue CAR T cell therapy, the patient undergoes leukapheresis, which is the process of obtaining the T cells from the patients. They're connected to a machine, sort of like dialysis, where the blood is filtered. We collect only the T cells that we want from the patient, and we return the rest of the blood to the patient. These T cells are then taken, brought to the manufacturing company, where through engineering, either through electrophoresis or through a viral vector, have the insertion of the chimeric antigen receptor, which is the receptor that we want the T cells to produce on their cell surface in order to identify and activate that tumor cell, the cancer cell. So once they are transduced with the chimeric antigen receptor, they are then expanded ex vivo, so in the lab, and then the product is shipped back to Northwell. At that point, once we have the product, we admit the patient for lymphodepleting therapy. So they get 2 chemotherapies, fludarabine and cytarabine, and cyclophosphamide are the most common ones. Once they receive 3 days of the chemotherapy, they have 2 days break, and then they are infused with the CAR T cell product. This requires a hospitalization stay of about 7 to 10 days. Unfortunately, most of them are, fortunately, most of them are non-eventful. However, we do need to monitor them for this period of time due to the high-risk complications that may occur. So the most common complications post-CAR T that we monitor very carefully post the infusions is cytokine release syndrome, neurotoxicity, also known as ICANS, cytopenias, infections, and for some patients who go into CAR T cell therapy with a very heavy load of cancer, tumor lysis syndromes. And I'll go into detail about each one of these. So cytokine release syndrome, also known as CRS, has an incidence of approximately 90% in our patients of any grade. There's a grade 1 to 4 depending on the symptoms the patient experiences. The onset for cytokine release syndrome is typically within 1 to 7 days post-infusion. And what this is really a massive cytokine release that leads to a severe inflammatory state in the patient, causing fevers, hypotension, hypoxia, tachycardia, fatigue, capillary leak. So they have a lot of edema that can occur. It is graded 1 to 4, and depending on the grade is the treatment that we give. So if the patient only has some fevers, we can give them tocilizumab, which is an interleukin-6, an anti-inflammatory that we can give, first line for 2 doses and see if they respond. Once they have fever plus another vital sign instability, such as hypotension, then they're considered to be a grade 2, and we start steroids in order to mitigate the inflammation that's ongoing in their body. Some patients do require vasopressor supports, oxygen. They do have fluid buildup. Which is, why we keep them in the hospital, so we can closely manage them. When CAR T cells first came out, this was one of the highest mortality causes that occurred until we learned how to mitigate the cytokine release syndrome. Really, tocilizumab was forefront. There's actually a movie on Netflix regarding the CAR T cell and how it first went into, and how it first helped this patient over at Penn in Philadelphia. So this is one of the reasons why we admit the patient for cytokine release syndrome and to monitor them and treat as appropriate. The second most, the second most, the second highest, the second common complication immediately post-CAR T infusion is the neurotoxicity. So ICANS, which stands for immune effector cell associated neurotoxicity syndrome. I'll refer to it as ICANS from now on. It has an incidence of about 20 to 60%, which really depends on the product. The higher, it is a higher incidence in the CD19 chimeric antigen receptors, less so in the BCMA chimeric receptors. So the onset for the neurotoxicity occurs a little later than CRS. Sometimes it can occur, but it tends to be a later side effect, usually within day 7 to day 10. It's really about the blood-brain barrier being affected and disrupted by all the inflammation that's ongoing, which leads to a encephalopathic, confused patient. They have difficulty speaking. They don't really know where they are. They can have seizures. They feel very tired, sometimes anxious or agitated, can't stay still. We use a tool called the ICE score, which really is a set of tasks that the patient needs to complete, including writing a sentence, making sure that the handwriting is complete. They also have to remember 3 objects, do serial sevens, sort of like a mini mental, but specific for CAR T cell therapy. Um, we manage the neurotoxicity with dexamethasone, so with high dose steroids. Tocilizumab has not been found to be very effective in managing this neurotoxicity. All our patients that have even a grade 1 neurotoxicity from CAR T are started on anti-epileptics for 30 days. And we stop them after 30 days if they don't have a seizure. But because of the high risk of seizures associated with neurotoxicity, they are started on this. So other complications that patients may have, tumor lysis syndrome, which is, which is seen in patients that have a high tumor burden, such as acute leukemias or lymphomas that have progression of disease at the time of CAR T. It is seen within days of the CAR T infusion. The features of it is electrolyte imbalances, hyperuricemia leading to AKI. Treatment is supportive, hydration, allopurinol, resveratrol, electrolytes. Cytopenias, I want to mention, is one of the major side effects that many of our patients face. Although the hemoglobin and platelets recover quickly within the first 30 days, the neutropenia post-CAR T infusion is often persistent for about 40% of our patients. It can last several months, and they are on growth factor support for these several months in order to bring up their neutrophil count. This is something that, is one of the downsides of CAR T. That persistent neutropenia does put them, even though we artificially increase their neutrophil count, it does put them at a high risk of infection, and they do need to take those neutropenic precautions. This is a very nice segue to infections. So they are at risk for infections for about 6 to 8 months post-CAR T infusions. Infections include bacterial, viral reactivations, or fungal infections associated with the prolonged neutropenia. Our patients are on prophylactic acyclovir and Bactrim for PGP prophylaxis as standard of care. We also monitor their immunoglobulin levels every 30 days in order to see if they would benefit from any immunoglobulin replacement. So anyone who has an IgG level less than 400, we would give them some immunoglobulins monthly. All these patients with CAR T also need to get all of their vaccines done again. So all their childhood vaccines need to be repeated starting at 6 months. We do not give them any live vaccines. So measles, mumps, rubella are not given until 2 years post-CAR T cell therapy. So they are at risk if ever they are in the presence of someone who has this active disease, especially with the current climate of against vaccinations. This is something that we do fear for our patients going through this. Any questions about CAR T cells before I move over to allotransplant?
Sorry, I just have one question. What is the duration of the therapy, the CAR T therapy?
So CAR T cell therapy is a one and done treatment. So we give them the infusion on one day, we monitor them for 7 to 10 days. The median time that patients stay in remission after receiving this one infusion of CAR T cells is about 6 months. It is disease dependent, and the load of the tumor volume at the time of the infusion also plays into this median response time. But it is typically 6 months of remission post-CAR T cell infusion, the median time.
Okay, thank you.
These are the current CAR T cell therapy FDA approvals, just for your reference. We do carry all of these here at Northwell Health now, but just for reference. Okay, so allogeneic transplant, really the goal of this is to replace the patient's hematopoietic and immune system with a healthy donors. So although I'm not talking a lot about auto transplant, I did want to underline specific distinctions between the two. In an auto transplant, we use a patient's own stem cells, and the primary anti-cancer mechanism that we're relying on is this high-dose chemotherapy that we give them, which is followed by the stem cell rescue in order to reboot their immune system. In allogeneic transplant, we are really using a healthy donor's cells, so not the patient's cells, but a healthy donor's stem cells. And we are using, and we use allogeneic transplant for the anti-cancer mechanism of providing them with a new immune system that can now detect cancer cells and provide this graft versus tumor effect. As far as what an allogeneic transplant timeline would look like, an allotransplant is typically considered after their initial remission, after they've achieved initial remission for their cancer. So patients have already received chemotherapy, and then they are referred to the BMT team for evaluation. Once we see them for evaluation and we think they are a good candidate for transplant, we do a series of tests in order to ensure that they are in good enough health to undergo this curative intent transplant. So they undergo echocardiogram, pulmonary function testing, infectious disease testing. They also get a dental clearance and social work clearance. When the donor is worked up and cleared and the patient is in remission, has undergone their pre-transplant evaluation, and everything is set, the patient is admitted to the hospital to receive what we call the conditioning regimen. A conditioning regimen is a treatment protocol that is specific to the patient's disease and to the patient's frailty or health score, if you want, where this is made in order to create a blank canvas in the bone marrow for the new stem cells to then to be able to migrate to the bone marrow and form the new immune system and hematological system. So the conditioning regimen can really be myeloablative, reduced intensity, non-myeloablative. Yes, frailty does have a role in deciding which kind of intensity of the conditioning regimen we will be giving. However, not myeloablative therapy is not necessarily better than a reduced intensity conditioning. Some lymphomas have greater efficiency. Lymphoma patients receiving a reduced intensity conditioning can do just as well as a lymphoma patient getting a myeloablative conditioning, but with less toxicity. And this is really the change in the landscape in the last few years, understanding that more aggressive chemotherapy in the conditioning regimen is not necessarily associated with better outcomes. So patient is admitted into the hospital, receives this conditioning regimen, typically lasting 5 to 7 days, combination of chemotherapy, sometimes radiation therapy, total body radiation therapy. And then on day 0, they receive the infusion of the donor stem cells. The donor stem cells can be HLA matched, HLA mismatched, haplomatched, and this will determine the GVHD prophylaxis that is started typically around day 3 after the infusion of the cells. So there's different GVHD prophylaxis regimens. They have changed over the years for the better, with less toxicity, more graft versus tumor effect, but with less graft versus host disease, which we'll talk about a little bit more later. And then post-infusion, they're monitored in the hospital for about 21 days until they start having engraftment of the white blood cells. Once they have engraftment, then we discharge them and follow up weekly with them as an outpatient. I wanted to point out that the immune reconstitution of our patients do not start until after engraftment. And when it does, even though the neutrophils have engrafted, the immune system is still not that of an adult immune system. The B cells, the T cells, they are not, they have not engrafted and they are not being produced by the new stem cells. So the neutrophils are really the first cell that starts, that you can see in the blood. However, if you do a full T cell subset or a full immune system subset, you will see that they have very low T cells, very low B cells. And this is why, even though their white blood cell count looks normal, they are at very high risk of infection. So common pre-engraftment complications that we see in our patients in the hospital, things that you may already know about: nausea, vomiting, GI mucositis. So they have a lot of ulcerations in their mouth, a lot of diarrhea that can happen. The cytopenias, yes, they are transfusion dependent, need some red blood cells, some platelets in the hospital stay. They can have neutropenic fevers, which we do start them on empiric broad antibiotics. They also have significant physical deconditioning. One of the statistics that has always shocked me is that a patient in the hospital spends about 90% of their time in the bed. And this applies to all of our bone marrow transplant patients. As much as physicians, we try to kick them out of the bed, tell them their bed is out of condition from 9 a.m. to 8 p.m. Patients find their way back into the bed. And this really leads to severe physical deconditioning. Given that they don't feel so well, they do have malnutrition, they have fluid overload, which really, post-transplant, them walking out of the hospital, they all say, "Oh my God, I feel so much weaker than I did when I walked in." I've listed a lot of the most common complications, their incidence rates, their time frame. I think for the sake of time, I'm not going to go through all of them, just more of an information if ever you wanted to go back through it. I did want to spend some time going through the most common things that we do see, that you may also see once they do go to Glen Cove Rehab, or that you see them at the outpatient clinic. So cytopenias post-engraftment. So although our wish is that all patients return to a normal hemoglobin and a normal platelet level, this is not necessarily the case for all. There are some patients that stay below the normal level. There are some patients that remain transfusion dependent. There's a variety of causes, including the medications that we give them as prophylaxis. Bactrim is great at lowering the counts. They could be undergoing a viral infection. They could have just poor graft function. They could have developed pure red cell aplasia, which is when there was an ABO major incompatibility between the donor and the recipient. They could at any time point develop relapse disease, which is always something that, as the transplanting team, monitor very closely to ensure that we act on it as soon as possible. So patients who remain with cytopenias post-engraftment, we provide them with supportive care, so transfusions for hemoglobin less than 7, platelets less than 10, if they're having fevers, for platelets less than 15. We give them growth factor for anyone with a neutrophil count below 1,500. We play around with their medications if we think that their cytopenias are from medications that we're giving them. We can also treat their pure red cell aplasia with some rituximab. Now, I know that some of the patients that we've sent over to Glen Cove rehab, acute rehab, we know that they had a few lung complications. So I kind of wanted to throw this slide in to talk a little bit about the lung complications that we see post-transplant. So the most common by far is fluid overload. We are very gentle with our diuresis that we give our patients during the transplant process because they have a lot of third spacing and a lot of extravascular fluid, which means that they will not respond to, the traditional Lasix or Bumex that we would give them. So we do gentle diuresis. Sometimes we even throw in some albumin with the diuretic in order to really try to bring that fluid out of the extravascular space intravascularly. An early complication that we can see in lung within the first 100 days is really bronchiolitis obliterans organizing pneumonia. This is very uncommon, 10 to 20%, even less in the most recent years, down to like 5 to 10%. It is something that we treat with steroids. It is a clinical diagnosis, and it does take, the evaluation of the pulmonologist, the BMT team to really come to a definitive answer that we think this is the most likely suspicion, and we will start the steroid, usually 0.5 milligram per kilogram, which we try to avoid as much as possible post-transplant. And the other lung complication that we have heard about is, not that we have heard about, but that we see is bronchiolitis obliterans syndrome, which is more seen after day 100. And this is the lung complication that is associated with graft versus host disease. It is not something that we would see by itself. Typically, the patient would have other signs of graft versus host disease, such as a skin rash, some oral lesions, some nail changes. They very rarely only present with lung graft versus host disease. Infections are the number one cause in the modern era of bone marrow transplant of mortality. Actually, 44% of early deaths in bone marrow transplant are caused from infections. So we pay very close attention to any patient who is displaying signs of fevers, cold, or anything that would make us suspicious for the development of an infection. Patients are on standard prophylaxis, standard antimicrobial prophylaxis post-transplant. So they stay on Bactrim until a CD4 count is above 200 for 3 months. They remain on valacyclovir for approximately 9 months until we start their vaccinations for zoster again. All patients are on posaconazole and antifungal until day 80, and then Levaquin if they are neutropenic. We do trend viral levels weekly, so CMV, EBV, and adenovirus are trended weekly. We do prophylactically treat patients with a CMV, with a high CMV titer with valganciclovir. EBV, a rapid rise in the EBV titer leads to rituximab treatments. Adenovirus, we can treat with cidofovir if a very high titer is seen as well. So graft versus host disease, one of the major complications with allotransplant, which is although it used to be the most common cause of mortality and morbidity and seen in about 50% of patients, I am happy to say that this is not what we see in 2025. The graft versus host disease prophylaxis regimens that we are now using has significantly decreased the incidence of acute and chronic graft versus host disease. Here at Northwell, we have novel GVHD prophylaxis regimens. So we, in our matched unrelated donors, we use a calcineurin inhibitor-free regimen, which we'll go through in a few minutes. And in our haplos, we use CAST, which really leaves them on a short course of tacrolimus. Now, all of our regimens include abatacept, which is the novel regimen, the novel a drug that is now being used for graft versus host disease. So what is graft versus host disease? Graft versus host disease is actually a reaction, an alloreaction. Once the stem cells are infused, the stem cells are reacting to the inflammation caused from the conditioning regimen before. So it's an immune reaction of the graft against the recipient tissues. In acute, we can see skin, GI, and liver involvement. In chronic, it can affect any organ, most commonly the skin and the mouth. Typically acute, we see within the first 100 days. Chronic, we would see after the 100 days, but there is this component of overlap or late acute that can occur as well. So as I mentioned before, every patient gets a GVHD prophylaxis regimen according to the donor type. These are the three prophylactic regimens that we currently use here at Northwell. The ABC is a clinical trial that we just completed, and we are now using as our standard for all matched, unrelated, or matched related donors. So it is, the patient receives bortezomib, which is an infusion on day 0, day 3, abatacept on day 5, 14, and 28, and post-transplant cyclophosphamide on day 3 and day 4. This has produced an acute graft versus, the results from our clinical trials show that we have 0 grade 3 or grade 4 acute graft versus host disease, and less than 10% severe chronic graft versus host disease. The standard of care that you'll find at most institutions is the post-transplant Cy, Tacro, and MMF for the matched donors. And then the CAST regimen, which is a combination of cyclophosphamide, abatacept, and tacrolimus, a short course of tacrolimus, is for our haplo donors. So as I mentioned before, acute GVHD onset occurs between engraftment and day 100. We see 3 main systems involved: the skin, so they can have a rash, diffuse erythema, they can have some blistering in severe cases. As far as acute GVHD of the gut, patients would have vomiting, diarrhea, very watery diarrhea, abdominal cramping. You can also see associated weight loss and a functional decline. As far as acute GVHD of the liver, you would find an elevated bilirubin, transaminitis, and elevated alk phos. We do grade these according to this chart. I threw it in there if ever anyone was interested to look back. This is what the skin rash typically looks like. So if you put your hand on top of the rash, you can actually feel that it feels a little bit like sandpaper, which is really telling for GVHD of the skin. Now, the treatment for GVHD, first line, as I said, we try to avoid systemic steroids at all costs. So we do try topical triamcinolone, which is a topical steroid when it's skin only. We can also give budesonide for GI only involvement of GVHD. However, if patients are not responding to that, or they have more significant grade, then we will start them on systemic prednisone, 1 milligram per kilogram per day, and we start titrating them as soon as they respond. We really try post-transplant to balance the immunosuppression versus the graft versus tumor effect. The more immunosuppression we give, the less graft versus tumor effect that we can have. Therefore, we limit the immunosuppression, including the steroids post. As far as for chronic GVHD, as I mentioned before, onset is typically day plus 100, day 100 and more, although it can happen a little earlier in the overlap syndrome. It can really involve any organ. The most common is the skin, as well as the mouth. But weight loss, failure to thrive, diarrhea, lung. They can become very stiff, so their joints start being very stiff and unable to really have some good range of motion is also something that can happen as a chronic GVHD. The grading is mild, moderate, or severe, depending on the number of organs that are involved. A lung involvement automatically gets you a moderate chronic graft versus host disease. And again, so these are the skin changes that can occur in the chronic graft versus host disease. As you'll see, they're very different than what can happen in the acute graft versus host disease of the skin. And really the difference in the rashes is from the pathophysiology of why acute and why chronic develops. These are the changes that you can sometimes see in the mouth. So they'll complain of a lot of dry mouth, excess saliva, but feeling very dry. And they have these kind of snake-like linguine planus changes in the mouth. Treatments, again, topical steroids, systemic steroids. We can use second-line agents such as ruxolitinib, ibrutinib, extracorporeal photopheresis, rituximab, in order to treat the chronic. So once a patient goes through all of the transplant, it is now time to talk about their survivorship, which is the most important because we do these transplant in order to bring them to a curative remission. We know that a lot of these leukemia patients who do not undergo transplant do eventually relapse, need more treatment, and can, die from the leukemia. So the goal of the allo transplant is really to bring them to a curative state, but there is no goal in bringing them to a curative state without good quality of life. So in the survivorship era, really our main focus is functional recovery. We want our patients to get back to doing the normal things that they enjoy, being able to walk around the block, being able to do all the gardening that they did or go to the gym. These are things that we want our patients to recover from. All our patients do also get revaccinations of all of their childhood vaccines. So that starts at about 6 months post-transplant. The live vaccines are only at 2 years. They have special cancer screening protocols that we use for them. So any patient at the age of 35 or 10 years after the transplant need to get mammograms, colonoscopy, especially if there was any radiation involvement in the conditioning regimen. The psychosocial aspect is something that is very challenging, especially for young patients going through allotransplant. We need to monitor their organ function, echocardiogram, thyroid studies, osteoporosis screenings, and obviously we monitor for graft failure and for relapsed disease. So I wanted to end on this quote. The part can never be well unless the whole is well. And this is really where bone marrow transplant is an integrative team. We cannot do this by ourselves. We need the help of all of our medical colleagues and especially of the PM&R cancer rehab team, which really, our patients that have went through the acute rehab, I can speak for them as some of them are my patients, and they are doing phenomenally well post-discharge. And that's a lot of our patients goes to STARS outpatient rehab, and you see them week by week gaining their strength, and they talk so highly about the care that they are getting that I want to say thank you to all of you for helping us make our patients do so much better.
Thank you
very
so much.
much.
That was such a great talk. And I personally just learned so much that I want to already have you back again. I did have one question specifically to the GI symptoms of graft versus host. So is graft versus host a clinical diagnosis only, or um, is imaging or like how do you do the final diagnosis? Because I find that so many of these patients have diarrhea. You and I recently shared a patient that had a lot of diarrhea. So if let's say we're taking care of a patient in rehab and they are having diarrhea and we're not concerned for C. diff, we rule that out. Um, how do we know that it's just gut malabsorption or whatnot, or graft versus host?
So I know exactly the patient that you're speaking of, and we did end up getting a colonoscopy for him in order to get a biopsy because ourselves, we weren't very sure.
Okay.
So is it a clinical diagnosis? Yes, the skin is a clinical diagnosis. The GI, there are some objective findings that we can rely upon. So getting a biopsy of the mucosa of the colon can sometimes help us in identifying if this is, a GI acute GVHD. It is when a patient has acute GI GVHD, they have nonstop watery stools. It just does not stop. And that patient that you're referring to kind of fit the clinical picture. Turns out he did not have GVHD with a biopsy. He did have other GI complications that are rare. So he had pseudodilation of all of his bowels during his induction chemotherapy, during the conditioning regimen, which we think is what is causing his malabsorption to this day.
Got it. But I guess what you're saying is, like, if there is a concern, do you treat, like, do you biopsy first and then treat, or do you try some steroids first?
It's very patient dependent and
Got it.
depending on the acuity. If they're having 1.5 liters of watery diarrhea a day and their GI is not able to do a scope within the next day, then obviously the patient's needs to be treated empirically if there's no other causes that are found.
Got it.
Yes, we rule out infection before steroids. I think that was
Got
a
it. Thank
question in
you.
the chat.
Any other questions from anyone else?
That was
Okay,
really great.
I have
I
a
hear
question.
none.
I have a
Oh, there.
question. Thank you so much for great presentations. And we start to see a lot of patients at STARS, compared to the quarter 1 to quarter 2, we start to getting more patients. And we noticed that a lot of patients are like falls apart, like they coming into the initial eval and then they had to stop the therapy and then they went back to the lot of admissions. So it's this kind of common process that people will go back to the hospital. And also, sometimes we have a challenge with the compliance with the patient coming into the therapy. Do you have any strategy or any like tips that we have to educate the patients, and then also any precaution that we have to follow with the patients, such as like wearing a mask or, like how important to like educate the patients. Sometimes patients coming in and they don't wear the mask and then we have to educate the patients about it. So we'd like to kind of know a little bit more about it.
Yes.
Thank you.
Thank you. Those are excellent questions. So for some patients, we do send them to the STARS rehab program before the transplant for them to gain more strength. It is widely known that the stronger you are going into the transplant, the stronger you will be afterwards. And it's less of a mountain to climb afterwards. So that could be the admission that you're referring to, where the patients are brought back into the hospital, for that. Now, there are some patients that have complications post-transplant. Anyone with a fever less than 60 days that's persistent, we bring them back into the hospital. If they have failure to thrive as an outpatient, really not eating, poor PO intake, we bring them back into the hospital, optimize them, before they're sent home to decrease the morbidity from the transplant. we do have to work in a coordination system, right? Because they need this physical therapy, and we need to take care of them medically. So what I would recommend, if ever you are having a patient that is not being compliant with their rehab, we have no way of knowing this, but if you reach out directly, if it's one of my patients, please always feel free to send me a Teams message or, an email and tell me, hey, your patient hasn't showed up. Is everything okay? Anything going on? And then that way I see the patient weekly and I can tell them, no, you need to go to your therapy. This is important for you. As far as the precautions to take with our patients, so they are immunosuppressed. So it is, very, especially within the first 6 months. If you're seeing a patient post-transplant, I would recommend they be isolated. So not with the general, the rest of the participants at the rehab. Wearing a mask, I would recommend for both the patient and the staff that is working with the patient, just because you are in contact with many other patients that could be carrying, COVID-19 and not know it yet. And viruses are very, very detrimental to our patients.
Thank you.
Thank you so much. Let me just stop the recording at this point, and thank you very much for that great info. So with that said,